Hey, good afternoon, everyone, and thank you so much for joining us today. My name is Melissa, and I'm a behavioral health consultant with OPEN, the Overdose Prevention Engagement Network. We want to welcome you to today's webinar, Voices of Resilience, Breaking the Stigma of Substance Use Disorder. During our presentation today, audio and visual capabilities will be turned off for attendees to limit distractions. We do encourage you to ask questions of our presenters. Please submit your questions using the Q&A function on the Zoom toolbar at the bottom of your screen. Click on Q&A, type your question, hit send. We'll address these questions as time permits during the Q&A portion at the end of the presentation. We are offering CME, Social Work CE, and McBAP credit for today's webinar, and we will have a slide up with the information about obtaining these credits during the Q&A portion of the webinar. We will also email the continuing education credit information after the webinar today. Today's agenda will deviate slightly from our usual format. We've planned a 90-minute session, which includes pre-recorded interviews with two individuals with lived experience and a presentation from Dr. Pooja Lajasetti on the effects of stigma on addiction treatment through her lens as a physician and researcher. We will devote the last 20 minutes to Q&A and open discussion with our folks with lived experience and Dr. Lajasetti. Today, we'll be focusing on stigma and its profound impact on individuals with substance use disorder. At Open, one of our core initiatives is to reduce stigma by offering education, resources, and trainings grounded in evidence-based practice. We also recognize the vital importance of amplifying the voices of those with lived experience. Recovery is deeply personal, and no two journeys are the same. By sharing these person-centered stories, we aim to highlight the real-life impact of stigma and the resilience of those in recovery. Today, we are honored to share the stories of two remarkable individuals who have courageously opened up their recovery journeys and the role stigma played in shaping their experiences. To highlight some of Open Stigma education materials, please check out our Stigma Reduction Initiative webpage and our stigma brochure. These resources offer a comprehensive definition of stigma in its various forms, explores its presence within healthcare, provides guidance on self-assessment of personal biases, and offers strategies for addressing stigma across different professional and personal roles. There are also additional educational materials within these resources, including a neurobiology of addiction guide. Going to give a brief overview of Open. The Overdose Prevention Engagement Network is a diverse team dedicated to improving lives and reducing harms of substance use. By engaging with individuals, communities, and organizations, we share education and resources to strengthen person-centered prevention, treatment, and recovery, with an overarching goal of developing transformative, evidence-based solutions to reduce harm and stigma surrounding substance use. We work to support healthcare providers and communities in understanding and addressing substance use disorders at every level. We offer a variety of evidence-based services and resources. We offer on-call consultation services to connect prescribers to our addiction medicine experts who provide guidance for managing patients who have substance use disorders or complex pain, and who can provide answer both individual treatment and technical assistance questions. We offer expert-led education and training sessions. Many of our webinars offer free CME, CEU, and McBAP credits, and for prescribers, all of our credits also qualify for the DEA-required substance use disorder training. We provide MOUD training for providers. While our trainings are complete for 2024, dates for our 2025 trainings will be announced soon. We will continue to offer a $250 incentive for primary care clinicians and advanced practice providers to complete one of our MOUD trainings. We hope this encourages confidence and willingness to help expand access to MOUD treatment. To prevent new persistent opioid use, Open established and continues to update evidence-based opioid prescribing and counseling recommendations. These recommendations are based on patient-reported outcomes and offer after various acute care episodes and provide data to inform opioid prescribing. Open also provides tangible tools to reduce harms of opioid and substance use, and our hope is to disseminate resources to places that need it most. We encourage you to partner with us and apply for our programs. We offer a free library of evidence-based printable educational materials for both patients and providers. Patient education materials can be co-branded for free and are available in English, Spanish, and Arabic. Provider education supports best practice implementation for primary care, acute care, obstetrics, pediatrics, and dentistry. We provide safe medication storage and disposal options. We assist groups all across the state in hosting local medication take-back events. We fund implementation of permanent medication disposal boxes for qualifying applicants, and we provide charcoal disposal bags and medication lock bottles for healthcare and community distribution. We offer overdose rescue support. We fund implementation of naloxone vending machine and distribution boxes. We also offer naloxone administration training. These trainings are offered in person or virtual and are free. You can access more information about all of these services more directly using these QR codes or by visiting our website. Open understands that effectively addressing opioid use disorder and other substance use disorders requires deep collaboration and tailored solutions to meet the unique needs of each part of the state. Our behavioral health consultants work directly with physicians, physician groups, and community organizations in your area to help build connections and networks locally throughout the state of Michigan. So now we're going to shift focus to the deeply meaningful stories of lived experience with substance use disorder from Nancy and Alex. We have about 26 minutes of powerful pre-recorded interviews featuring Nancy and Alex. Nancy is the mother of a daughter with lived experience, and Alex is someone with lived experience of their own. In these interviews, they both reflect on their journeys with substance use disorder and how stigma has shaped their experiences with treatment and recovery.
Well, my daughter has told me that at the age of 6, she remembers feeling not right and different than everyone. She felt different than her twin brother, her siblings, her friends, that she was never happy and she didn't feel like laughing when everyone else did. So she just played along and compensated and actually overcompensated. And she was always the outgoing, easy-go-lucky kid. Then at age 10, she had seizures that couldn't be controlled, and she was in ICU for a while. And when they were finally controlled, I saw a big shift in her personality. And what I saw was a bipolar. I grew up with a father with bipolar, and her behavior, the way she spoke, the way she looked at me, just mimicked it completely. So when she was 11, she had to have emergency oral surgery, and they gave her a laughing gas. And again, she later told me that that laughing gas gave her a feeling that she knew she was going to seek for the rest of her life. So when she was about 13, she started playing around with marijuana and alcohol with her friends in town. And the difference was that her friends didn't do it to the point where they couldn't stand or they were sick, and she couldn't stop herself. And it got worse and worse as time went on, and we had to intervene because she was doing very dangerous things, and she was either going to kill herself or somebody else. So she started her first treatment at 16, and she's been to about 12, 15 treatment centers since. Another thing that happened was when she was 11, a distant uncle came to visit, and he molested her. And again, I didn't find this out until later. And that was right at that point where she had started acting different. I knew that she was bipolar. I took her to so many different doctors, and everyone told me I was projecting. It wasn't possible, but there was no question in my mind. At age 15, she had a serious suicide attempt where she was not awake for 3 weeks. And when she came out of it, the doctor said she's bipolar. So then they started treating her, but it was hard to get her to take her medication, and she got worse. So at age 16, we had to send her to get help elsewhere to save her life. And that went on and off for the next 10 years. She pretty much missed every holiday with the family. We had a few family trips, but we really couldn't go away because we didn't know what was happening with her. She'd run away from these treatment centers, so we had to always be around. At about age 21, by that point, she had gotten into heroin and cocaine and acid, and she was taking about as much of it as she could. And she said she would take anything and everything. She knew she could die, but she didn't care. So that was a very, very scary time. And I would say she hit bottom at about age 21. And she really wanted to get better. So we continued with different treatment centers and treatment at home. And she would get better and then fall off the wagon and get better and fall off. And it wasn't until she was about 26 that that stopped. And she has been largely sober since then, but we've had plenty of scary times where she wasn't. She's now sober 7 months, and I'm grateful for every day. It was very challenging supporting my daughter through this. First of all, I had 3 other children. And secondly, at that time, people were not talking about mental illness. They were not talking about substance use disorder. It was a real thing of shame. And we lived in a very small town, and people were, when they got wind of what was going on with her, they would go to the other side of the street to not have to walk by me. We were really shunned, and we really didn't have anyone to reach out to. We didn't know about that there were addiction counselors, or that we could get help for our kids, our other children, and for our family. So it was very difficult on my marriage, and it was very difficult on my other children, and they still have a lot of battle scars. But most of all, it was very difficult getting the help that she needed. I think, or I know that if my daughter had gotten treatment when I first went to the psychiatrist and told them what was going on, that she wouldn't have spiraled down as she did. But that was pretty much the story of, or has been the story of, her whole journey, is not getting the help that she needs when she needs it in the right way. My daughter is very afraid to go to doctors. She's afraid to go to the hospital when she has to. She has had a lot of bad experiences with doctors. For instance, one time she had a seizure. She has epilepsy, and when you put drugs on top of that, she has seizures often enough. The ambulance came. Her roommate called the ambulance. She was in it. She was still partially seizing, and they looked up her record, saw her background, and the paramedic told her to stop faking it, and told the others she was drug seeking, and told her to not try that with the hospital. She wasn't going to get any drugs. And they went in and they told the hospital, as they were wheeling her in, that she was there drug seeking. Now, whether she was sober or not, my daughter deserved the care that anybody else would get. My daughter was in the hospital one time after a bad incident, and she was in the ER, and the heart monitors kept going off. And the doctors had stuck her way back in a room and not come in to see her. And this happened over and over, and I can vouch for it because I've been there and seen when they look at her background, they just leave her for hours. Anyway, she really needed help, but so the nurses would begrudgingly come in after it was beeping for a while and turn it off. And it happened several times. So a nurse finally came in and unplugged it. And as it turned out, my daughter had a congenital heart problem, and her heart was racing up to 220 beats a minute. She eventually had to have surgery for the issue. She could have died only because of her background, but she didn't get the care. There were times when she had really felt empowered by a couple doctors. One was the cardiologist that she went to who did the surgery. And when she went, she was about 5 months sober. And he stopped and he said to her, "That is fantastic. You should be so proud of yourself. That's really big." And she called me after that just elated, even though she found out she was going to have surgery on her heart. She was just so elated. Another time, she had had a car accident and she had stitches in her forehead, and she was told that they were the kind that just dissolved. Anyway, she got a bad infection and went to a walk-in clinic. The doctor that took the stitches out and cleaned out the infection realized that this was not a very compassionate job that was done to her, and he was angry on her behalf at the doctor who had done it. When the cardiologist listened to her and explained her illness and explained to her that she did not cause it, she got the help she needed. And she also gained some of her self-respect back, which had been taken away in so many ways. And I think, that along with a few special, very special people at treatment centers who went way out of their way to really get to know what her underlying issues were and who didn't give up on her. I think without that, she wouldn't be here today. And those are the people that we need more of. Well, I think healthcare providers really need to be educated, and I think it should be mandatory that whether it's a doctor, a nurse, a paramedic, anyone in the health-related forum needs to be educated both on mental illness and on substance use disorder, that it is a disease just like any other physiological disease, just like cancer or diabetes, and that people are to be treated with respect, and that their illness should be treated just the same as any other illness. Right now, that's not the overall consensus out there. And I think only with mandatory education towards this are we going to see a change. I think it is utmost important to the trend that's going on where where the overdoses are higher and higher, and mental illness is worse and worse. Suicide rates are higher. I think it is because there's no early intervention. There's no intervention when it's really needed because people are misunderstood. And that is the biggest travesty of all.
Hello, my name is Alex Jenner, and I am a certified peer recovery coach in the Upper Peninsula of Michigan. From early on in my childhood, I had some traumatic experiences that I didn't even realize were traumatic until much later in my life. I have a long family history of alcohol and substance abuse, and some of which directly impacted me growing up. I remember feeling a lack of nurture and comfort growing up as a child. And I never, something seemingly as simple as never having memories of my mom playing with me as a child turned out to have lasting impressions later on in my life. Around the age of puberty, I began experiencing some distressing symptoms of depression and anxiety, and I really struggled with that. I began coping by using marijuana and alcohol at that age, and it progressed on through there. I wasn't really shown what healthy coping skills were or when to use them, so that was kind of my go-to. All throughout high school, though, I did very, very well. I was a straight A student. I received multiple scholarships to go to college. I looked for opportunities to volunteer my time in my community. I was addicted to various substances, though, and my addiction grew very quickly. In college, I graduated with an associate's degree in nursing and got my RN license shortly thereafter. And that's kind of at the age of 19, I was still experiencing these feelings of what I would describe as crawling out of my skin. I was so anxious. It was all consuming to me. I had asked a friend if they had something, really anything that would help relieve those symptoms that I was facing. And they offered me prescription opioids. And so that's when I began taking those. And as the months went along and I continued to take them daily, I really didn't, I thought I had control, but the addiction grew and grew through that time. And I began to realize that the days that I didn't take the opioids, my anxiety was 10 times worse. The feeling of crawling out of my skin was way worse than it was before even. So I continued to take them, and I did for years. Around the age of 23, I had begun smoking heroin. At my first nursing job, I had experienced some trouble related to my substance abuse or substance misuse of opioids, and they fired me and reported me to the board of licensing for Michigan, in which that board had required me to begin a treatment program called the Health Professional Recovery Program. When I first started MOUD, it got me out of the cycle of constantly having a craving or withdrawal. It allowed my mind to be freed of constantly thinking of using or getting things to use, which thankfully it did that, because that kind of gave me the time to think about other things like jobs and all that, of relationships with other people. I struggled with, in the beginning, I had still, although it helped me with those things, the craving and withdrawal cycle, I still struggled emotionally, getting control over my emotions mentally. I still felt very anxious in the beginning, depressed, withdrawn. I definitely just felt like I didn't want to do anything. So that was very hard for me in the beginning. So HPRP, the Health Professional Recovery Program that the Board of Licensing for Michigan had required me to see, one of their requirements was to see an addictionist, and the closest one to me was over 2 hours away, and I had to see him on a monthly basis. Once I was ready to get sober in that. I had asked him for help, and he prescribed me Suboxone sublingual films, and that is how I started taking those. Eventually, after about 2 years, I was referred to somebody who was actually much closer to my area, who wasn't available before that. And they put me on Sublocade injections. MOUD allowed me to begin my life. I had been under the influence of some type of mind-altering substance for so long that I didn't know what living a life actually felt like, or how good it could be. I went from living with my parents to having my own apartment. I have reliable transportation. I can hold a job now. Issues with my health have finally been addressed. I can set healthy boundaries when it comes to family, friends, and significant others. I respect myself. I find enjoyment in doing things again. I am no longer ridden with the guilt and shame that I was before over my addiction. And really, I never imagined my life could be as good as it is now. I was absolutely consumed by my addiction in every way, from the time I opened my eyes in the morning to the time that I went to bed at night. Those addictive thoughts and behaviors were all I knew. And yes, starting MOUD gave me the ability to do more with my life than finding and using drugs. But I still didn't know how to manage my thoughts, emotions, behaviors, any of that in any other way besides using drugs. That awareness didn't come until I began using MOUD for nearly 3 years and had a devastating experience. In July of 2022, I had found my brother's body after he took his own life. He had also struggled with some issues with addiction and the long-lasting effects on his mental health. After that experience, things changed in me. That could easily be me. After, I was on MOUD for nearly 3 years already at that point. So to have that thought that I could take my own life potentially was very scary. And that's kind of when I began to realize that I needed, to know what healthy looked like. So I began, doing it for the first time in my sobriety. I stopped drinking and using marijuana. I began doing the things that were recommended to me by people that were actually healthy and knew what it was like because they had been through it. I began breaking the patterns of my addictive thoughts and behaviors and gain control over them and my emotions after that point. In October of 2023, I ran into an issue with my insurance coverage for the Sublocade injection. And that was when I received my last Sublocade injection, which has been almost a year now that I've been off of any type of MOUD treatment. I have personally encountered a lot of stigma around the use of MOUD to get sober. One instance that stands out in particular is the time that I had to go to urgent care. I had known issues with my heart at the time, and I was experiencing new symptoms of swelling in my legs and in my face and a rash that had appeared on my face. I was very honest when I went in about my history with addiction, and at the time I was on Sublocade injections, I believe. The nurse was fine, but the doctor that came in, unfortunately, seemed to have already made up his mind before ever seeing me. He decided that the reason why I had swelling in my legs was due to injecting and the rash on my face was picking, and that I was using meth and seeking drugs. He actually went so far as to call my MOUD treatment provider and tell him that he thought that I was on meth and they're using there to get drugs. So that really made an impact on me, you know. After that point, I mean, I still haven't been to urgent care emergency alone because I don't feel comfortable. I feel like I need to have somebody there with me to advocate for me. I got very lucky with my MOUD treatment providers, I think, but yes, mine were very, very supportive, very, very nice. They, you know, I mean, I wasn't perfect in the beginning. Like I said, I was still using marijuana and alcohol for a long time. And they, you know, continued to support me and encourage me and push me towards a better life. And my greatest support outside of that has been my sponsor, who has been extremely caring and comforting and understanding and supportive. So the stigma that I've experienced has made me leery of who I tell about that part of my recovery journey. I don't bring it up to family even, or people that I just meet or in 12-step groups, because I've heard the same thing, variations of you're not sober until you are on nothing, completely abstinent, not on any type of MOUD treatment or anything like that. And that is, you know, to me, I just can't bring that up. So I wish healthcare providers understood that not everybody is the same. Sounds basic, but people who struggle from addiction often get lumped into this category that we are trying to manipulate them to give us drugs, and that we're going to either misuse or sell our MOUD treatment, and that we don't actually want to get sober. Recovery is a known disease of remission and relapse, and you know, most people aren't able to change so much so quickly that they never relapse. When you've spent 10 years in addiction like I have, or more for others, that's all that you really know is just that lifestyle, and that's the only way that you know how to cope. Addictive thinking and behaviors, all the things that lead you back to drugs are the only things you know. So it's hard to even tell that those things, behaviors, environments, friends and family are unhealthy and need to be changed. If you take away MOUD as a form of punishment, when somebody relapses, they oftentimes get very desperate, and then they may never get the chance to know what recovery and healthy look like.
I want to extend our deepest gratitude to you, Nancy and Alex, for sharing your recovery journeys with us today. It takes incredible courage and vulnerability to open up about such personal experiences, and your willingness to do so not only helps reduce stigma, but also provides hope and inspiration to others. Thank you for your bravery, your honesty, and for contributing to this vital conversation. With that, we are going to switch gears, and remember, Alex and Nancy will be here for the Q&A and discussion portion. And I'm going to introduce our next speaker. Our next speaker is Dr. Pooja Lajasetti, and Dr. Lajasetti is an associate professor of internal medicine and practicing physician with a focus on addressing barriers and developing interventions to better treat chronic pain and addiction across medical settings. Dr. Lajasetti received her medical degree from Johns Hopkins School of Medicine, completed her internal medicine residency at Massachusetts General Hospital, and received her master's degree in health services research via the Robert Wood Johnson Clinical Scholars Program at the University of Michigan. She also holds a joint appointment in the Center for Clinical Management and Research at the Ann Arbor VA, and is a contributing member at the Institute for Healthcare Policy and Innovation. Clinically, she is boarded in both internal medicine and addiction medicine and treats patients across the spectrum of chronic pain and addiction. Her research has been influential in understanding stigma and disparities for individuals with pain and addiction. Specifically, her work has highlighted treatment across barriers for individuals with chronic pain, following policies aimed at reducing prescription opioid supply and racial disparities in the receipt of medications for opioid use disorder. She has been funded by multiple federal agencies, including NIDA, SAMHSA, and the VHA, and also by foundations, including the Michigan Health Endowment Fund and Blue Cross Blue Shield Foundation of Michigan. She also co-directs the research and data domain of the University of Michigan Opioid Research Institute. Thank you, Dr. Legesetti, for being here today. We're excited to have you, and I will turn it over to you and stop screen share.
Great. Thank you so much for having me. I also just wanted to say thank you to Alex and Nancy for taking time to share your story. And I will be kind of offering a complementary kind of academic perspective of stigma for the next few minutes. So can everyone see the right screen?
I think we're seeing the not the presenter view.
Okay.
It doesn't look like it's in slideshare mode yet.
Okay. Let me just turn this. Let's try again.
Mm-hmm.
How about
Perfect.
now? Okay, perfect. Okay, great. Thank you so much. All right. I have no conflicts of interest to disclose. I do receive funding from a variety of agencies, but they were not responsible for this talk. And I just wanted to state, I do work for the VA, but my views do not represent the views of the Veterans Health Administration. So I will start by, my main objectives today will be to define stigma, provide examples of how stigma can impact access to treatment. And we've heard a little bit about this already from our lived experiences, and then also discuss potential solutions. So let's start with kind of just the basics, defining stigma in addiction. What is stigma? We use this word a lot, but it's important to kind of remember the definition, which it can include negative attitudes, stereotypes, and beliefs about an outgroup relative to the dominant group in society. And in healthcare, this can manifest in many different settings. It can manifest as general stigma that kind of comes from the community or the public. It can manifest as stigma that you experience from your clinical or healthcare provider. And it can also be stigma that you manifest about yourself, because a lot of us do have these feelings of blame or shame that can also manifest as self-stigma. So with respect to pain and addiction, and particularly around opioids, stigma is really complicated and intertwined. So I have this diagram where I'll talk a little bit about this, but, there's a lot of stigma just around pain. There's a disbelief in people's pain. We can't measure it with, a lab value. There's no x-ray that tells us exactly how strong somebody's pain is. And so often within the healthcare system, you will find kind of clinical encounters where we're trying to distinguish whether pain is kind of real or not real. And those words in themselves are stigmatizing. Organic or non-organic pain, again, stigmatizing language. And so we're trying to assess kind of how much pain an individual has, yet pain is incredibly personal and can be incredibly subjective. There's also, when a person presents for pain in the healthcare setting, especially when there may be a utility of providing a medication such as an opioid, there's this automatic assumption that maybe the person has addiction. And another kind of stigmatizing term that gets used a lot is drug seeking. And so we will often hear about individuals talking about that. And then more recently, with kind of more and more studies coming out, kind of questioning the efficacy of pain, particularly for chronic issues, There's this worry about kind of the legitimacy of prescription opioids for pain treatment at all. And so this has really kind of led to a lot of hesitation on clinicians' parts around anything related to pain, addiction, and opioids. And so all of these three things together make for a really complicated scenario of stigma, where stigma can be multifactorial. So how can this look like for those who are actually suffering from a substance use disorder? There's studies that have kind of qualitatively interviewed individuals who are in treatment programs, and they've said that social and self-stigma made it more difficult for them to continue in a treatment program. They often felt frequently blamed for their condition. And they often internalize this social stigma, which can harm their chances for recovery and addiction. And this is a quote from one of these papers, I felt and still fear of being stigmatized, so keep my past and my recovery a secret. But it's my secret, and I do not intend to share anytime soon because I fear the repercussions. And so we hear about this a lot, where there's so much shame and worry around the stigma around the disease that there's kind of hesitancy to share this. So how can this affect care in the healthcare system? There's so many ways it can affect care in the healthcare system, and I can't get into all of them. And so I've kind of chosen a few examples to really highlight what this may look like. But the list could be endless, and I'm sure others have other stories to share as well. So the first example I'll talk about is kind of stigma can manifest within the electronic health record. So when a person kind of comes to seek care within the healthcare system, clinicians will see the patient, and they're required to document their interaction in the electronic health record in the form of a patient note. And in these notes, we can often see kind of clinician bias about kind of the encounter that can then perpetuate healthcare biases in the future, because everybody can see this healthcare record every single time a person presents to the healthcare system. So just to give you kind of an example of this, like this is, for example, let's say in the emergency room. When a person comes to the emergency room, there's like a brief encounter with a triage nurse where they'll kind of take your vital signs, and then they'll write this very brief triage note that will just say, so-and-so, in this situation is coming in with lower abdominal pain today. I ate 2 bananas. I usually eat 1, then my GERD and burping started acting up. And so it'll be this brief description of what the patient says. But sometimes even that brief description can negatively impact how quickly that patient gets seen when they're on the board for the emergency room docs. And so, here's kind of a schematic of what this could look like. So your patient sees the triage note. The triage note is written by the nurse. The inpatient clinicians can also see that note. And this affects the care that you receive from the bedside ER nurses, potentially the social worker, potentially the ER physicians, who then write their own note that could then perpetuate this cycle even more. And so, I highlight this just as an example of where stigma can manifest in a very written format. And here's some kind of examples of words that can be stigmatizing in the notes. Apparently he was sitting at home on the floor feeling fine when suddenly he felt fatigued all over his body. He claimed it was from fluid in my knee. These words, such as apparently and claimed, kind of discredit the patient or, may kind of bias a future interaction. The next quote here from another study: classic thing in emergency medicine is that a junkie comes in, you give them naloxone, they are pissed off because they blew their high, then you are pissed off and aggressive, patient on your hand. And so all this language, is perpetuating bias and stigma. We see words like this. This is a study that was done in 2022. And this is not just around addiction, but it can be about other stigmatizing healthcare conditions too. You can describe patients using things like non-adherence, which kind of, hint at some behavior that could impact future interactions. Clinicians may use kind of scare quotes. Patient had a quote reaction to the medication. It's almost as if they don't believe that the reaction happened. Compliance, or kind of these evidentials as well. And so this, to me, language in the electronic health record, I bring this up mainly for the clinicians in the audience because it can be kind of a way for us to minimize future bias interactions, and something to be kind of mindful of as we kind of write our notes. The second example I'll talk about is kind of limiting access to pain treatment. So this may not be kind of solidly around opioid use disorder, but it is around receiving opioid therapy for pain treatment, which people with opioid use disorder can have as well. And this was a study that our team led, which was really focused on understanding how opioid prescribing policies affect access for patients with pain. And the background of this was that, as many of you in this room know, there's been quite a few laws federally, and also quite a few laws, within the state of Michigan where I practice. And there's also many kind of rules within our institutions that have called on kind of more careful opioid prescribing to decrease inappropriate use. And over the years, we have shown that these kind of opioid prescribing laws have led to a significant decrease in opioid prescriptions. However, we also hear from individuals, I hear from my own patients that talk about kind of, yes, opioid prescribing has fallen, but the bad is that there's pain patients that are suffering. And I started to hear this a lot as a primary care physician. I would have patients that were coming to my practice who, had lost their last prescriber. And so really wanted to see, like, is this just a one-off issue, or how much is this actually happening? And so one thing that we sought to do was to quantify just how bad these treatment access issues were. And we called primary clinics to assess whether patients on long-term opioids, prescribed opioids, have access to scheduling new patient primary care appointments. And we did this by simulating a patient who needed an appointment for a new primary care physician. This is a method that's been used in prior studies of healthcare access using kind of these simulated calls. And it reduces the response bias. If we just kind of called up a bunch of clinics and said, do you take patients? We're conducting a study. A clinic may feel inclined to give us information to be socially desirable that may not be true. So we called 667 primary care clinics in the state of Michigan. And we asked them first about what type of prescribers they had, clinician, MDs, APPs, general prescribers versus individuals who were trained to treat addiction. We asked them what types of insurances they accepted. And we initially asked them, do you even have any availability for a new patient? We then randomized 194 of the clinics that were accepting new patients, and we called half of them with a patient who had Blue Cross Blue Shield insurance and half of them with a patient who had Medicaid insurance, because we didn't know how much insurance status would affect treatment access. And we had RAs call each clinic trying to request a new appointment for their mom who had chronic pain. And so they would reveal in the phone call that they were calling for their elderly mother. They would tell, what health insurance she had with respect to Blue Cross Blue Shield or Medicaid. And during the initial phone call, they would say, before we get too far, is it okay if my mother takes opioids for pain? And what we found was that 40% of the clinics that we called, who initially did state that they had availability for a patient appointment, kind of on the phone, kind of backtracked and said, "Ooh, we actually can't take your mom for that new visit." And it didn't really matter whether the mom had Medicaid or Blue Cross Blue Shield. So why are clinics closing the door? And so we qualitatively called these clinics again, and interviewed them, patients, providers, and office staff. And we said, why are you closing your doors? What is going on? And the questions focused on experiences with prescribing and receiving opioids, opinions about opioid-related policies, and challenges to providing or accessing effective care for chronic pain. And we heard a lot, and and a lot of it felt very real. A lot of folks talked about administrative burdens. We're having to do a prescription drug monitoring check, a house drug screen, a controlled substance agreement, the opioid start talking form, which is specific to Michigan, patient counseling. It's just so time intensive, and we don't get compensated for this. We also heard a lot about fear of sanctions and liability. The DEA is kind of following things, and there's more liability. So there are lots of patients that we are trying to keep off of opioids. And those two reasons were heard the most. But we did also question how much of this was just stigma around this patient population. Like, was it all administrative burdens, and was it all fear of sanctions? Or maybe was this patient population just a patient population they didn't want to see? And so we expanded our study, and we did it again to see if we could kind of figure this out. And we called now clinics in 9 different states. And this time we called each clinic twice to schedule a new patient visit. In this scenario, the patient said, I've been taking Percocet for years, but scenario 1, my doctor just retired. Scenario 2, my doctor stopped prescribing it for me. As you can imagine, scenario 1, my doctor just retired, is seen and potentially seen as a more benign reason for needing a new primary care physician. However, scenario 2, my doctor just stopped prescribing it for me, could lead to all kinds of conclusions about why that happened. Potentially, were they misusing the opioid, or were they not? Who knows? But it is a little bit more worrisome for problematic issues. And so what we found when we called 452 clinics. Each clinic got both patients. So 75% responded the same to each scenario. This is actually what you would want, especially if the clinic had a policy on which patients to accept and which ones not to. 32% said, yes, set up an appointment with us. 43% said no to both scenarios. So this was similar to my last study that said 40% said no. But 25% of the clinics responded differently to each scenario. And they were twice as likely to accept a patient whose doctor retired as opposed to one that stopped prescribing to them. So this really hinted that in some patient scenarios, in a quarter of them, the front desk staff has some leeway in deciding which patients they want to admit and which ones they don't, which is opening itself up to biased interactions. And so there might be stigma, the implications towards individuals with perceived aberrant use. However, I would argue that, that's exactly the patient population that we should be accepting more, right? So if there is a perception of aberrant use, we should probably be opening our doors to these patients rather than denying care, because they're the ones who would likely benefit the most. And then one of my final examples will be around the low uptake of medications for opioid use disorder. And Alex touched about this a little bit in her video. So, as a reminder, there's only 3 medications that are medically FDA approved for treatment of opioid use disorder. There's methadone, which can be administered at a regulated outpatient treatment program. It's public setting and usually requires daily dosing, although you can earn take-homes. There's buprenorphine, also commonly kind of marketed as Suboxone for many. And it historically required a physician who was waivered, although that's been eliminated in the last year. You can receive it in a private office-based setting, and it can be, you can get kind of refills where you can get it, as a monthly refill, similar to other medications. And then there's naltrexone. This can be administered by any prescriber. There is an oral version, but there's an injectable version that's approved for opioid use disorder. And its uptake has largely been limited because it requires a patient to detox from their full agonist opioids for many days. And so that makes it really challenging to initiate this medication in many settings. There's also common myths and misconceptions around medications for opioid use disorder, particularly methadone and buprenorphine. Both of those medications are opioids, as well. And so there's a common conception that MOUD replaces one addiction for another. Now, it is certainly replacing one opioid for another, but I have this picture here. This is actually a woman putting on a nicotine replacement patch for smoking cessation. I highlight this because we do accept kind of these types of substitution therapies for other conditions with a lot less stigma. We don't judge people when they're wearing the patch for smoking cessation. And we do this often in our daily lives, even when we're, let's say, dieting. We might substitute a more healthy, sugary option in place of a slice of cake. And so we do these types of substitutions in our regular life for a lot of different conditions, but for some reason, methadone and buprenorphine carry a lot more stigma for the people that are using it. Another common myth and misconception is that if you're using these medications, you're somehow kind of weaker or inferior to those who have elected to not use those options. People kind of put those who can kind of stop without the use of methadone and buprenorphine on some like a higher pedestal. And I would say that here, the hard part about this analysis, this kind of common misconception is that we actually have robust randomized controlled data evidence that shows that when you use these medications, it's actually more effective than non-medication-based therapy at reducing your risk of overdose. So with all this in mind, the uptake of these treatments remains quite low. Fewer than half of treatment programs even offer medications for opioid use disorder. And of patients in these programs who might benefit, only a third actually receive them. And this is really due to a lot of what we call intervention stigma around these ideas of replacement therapy, the benefits, kind of the superiority of abstinence-based approaches. And there's also fears around racial discrimination, which I'll talk about here. Historically, there's been, evidence-based racial disparities in treatment access to these two options. When buprenorphine back in the 2000s was approved to be prescribed by general practitioners if they had the X waiver, there was actually kind of congressional regulation that pushed this forward that said that buprenorphine was the right drug or the better drug for white suburban patients who didn't need to go to the methadone clinics, which have been historically largely in urban and Black communities. And so it was kind of marketed as this option for kind of a different clientele by kind of privately practicing physicians. There was a study done in New York City that kind of showed this disparity and found that the areas with the highest proportion of Black and Latino low-income individuals had the highest methadone treatment options, while buprenorphine and naltrexone were more accessible in white high-income patients. And this was a study that our team did that kind of showed that in outpatient treatment practices from 2004 through 2015, while buprenorphine use had kind of dramatically risen over the years, it had largely risen in white individuals and in individuals who had private insurance. And I think some of these have changed more recently as Medicaid has done a better option of making buprenorphine widely available. So in the last few minutes, I'll talk about what we can do to fix this. And this is there's so much we can do to fix this. So I'll just touch on a few potential options. One thing we can do is kind of education opportunities, things such as this webinar, but also kind of within our health professional schools. Our team has implemented a 4-hour hybrid workshop on OUD treatments that really focuses specifically on stigma reduction. And in a class of about 200 medical students, we were able to show that after the workshop, they had a decrease in stigmatizing attitudes towards opioid use disorder and actually felt kind of similarly towards a patient with opioid use disorder as they would if they were treating a patient with diabetes. We showed that we could increase their knowledge around these treatment options, and that these improvements in knowledge were irrespective of past training, such as the X-waiver training. The other thing we can do is think about how policy change really affects access and the way we perceive these treatments. So, Xing the X-waiver was one such policy. It was always okay for buprenorphine to be prescribed for the indication of pain by any prescriber. So same medication, same risk profile, same toxicity. If a patient said they were taking it for pain, it could be prescribed by anybody. But if a patient said that they were taking it for their opioid use disorder, it required an X-waiver, which was 8 hours of additional training and applying for the ability to do it. So eliminating it really kind of put buprenorphine on the same playing field for whether you had it for pain or for opioid use disorder. And by doing that, you decrease some of the stigma and fear around using this medication that clinicians might have and might just kind of perceive as like, well, it must be much more dangerous. That's why I'm having to do this extra training. But the risk and the safety profile is the same, whether you're using it for pain or opioid use disorder. And there's a lot of other kind of policies that are out there that are debatable, but may have different kind of ramifications and consequences with respect to decreasing stigma around drug use. The other things we can do is kind of be conscious of our own biases when treating patients with addiction. We can think about changing our language. I talked a little bit about this with respect to the electronic health record, but this is kind of a table that, the National Institute of Drug Abuse has put out there, and kind of thinking about words that we can avoid. Instead of referring to somebody as an addict, talking about a person with addiction, just because, their identity shouldn't be completely consumed by their condition. Talking about people as being clean or dirty, again, it's, we don't kind of think about individuals in that way, but we could talk about them, being substance-free or drug-free. And we talked a lot about kind of replacement or substitution therapy. We can also just be an advocate, and, when we kind of encounter the stigma, really kind of correct these biases. And I have this picture of the toolbox. I talk about this a lot with respect to medications for opioid use disorder. I think it's absolutely nuts that we only have 3 drugs that are on the market to treat opioid use disorder. We have like no drugs on the market to treat stimulant use disorder. This is crazy. This is a crisis in our country. And, we have, many drugs to treat diabetes, many drugs to treat HIV, many drugs to treat a lot of other chronic conditions. And so when we only have these 3 options, or, using no medication, it really feels like we should just kind of be, offering the toolbox, offering the arsenal to anyone who needs it, because, limiting that toolbox when there's only 3 options seems, it seems like people should be able to choose their recovery path and have a choice in that. And, and then as I kind of wrap up and close, I think the biggest thing we can do, especially for myself as a healthcare professional, is to just listen. Listen to people who have lived experiences. And so, today, I don't want to offer up any more solutions, mainly because I think, I really want to leave space for Alex and Nancy to come back and join us, and we can listen to their ideas on what they think we should be doing to help decrease this stigma within the healthcare system. So I'm going to stop my share and invite Alex and Nancy back to join.
Thank you so much, Dr. Legistetti. This was a really, really helpful presentation. There was a comment in the Q&A saying these studies are wonderful. Thank you so much for the insight. Is there anything, Dr. Legisetti, that you wanted to have Nancy or Alex speak on?
Well, I mean, I think for me, I think it would be really just, I would love to hear, you know, how you feel like with your own interactions with the healthcare system, Nancy for your daughter and Alex for yourself. You know, just helpful advice that you would give to kind of a clinician on ways that they can think about their own biases and stigma when caring for a person who might be suffering from a substance use disorder.
I'll go ahead. Hi, my name is Alex. I shared my personal lived experience with specifically opioid use disorder, but addiction in general for myself. When it comes to getting into sobriety and recovery, I think just the realization that people don't exactly know, people who struggle with that don't exactly know what healthy looks like I said again, and that there is a lot of changes that you have to make to be successful in recovery and sobriety. And people aren't always aware that some things are unhealthy in their lives and what they need to change. It's not an easy thing to change your entire life. So I think that just giving them that grace and realizing that, yeah, it's not that easy to change everything.
I agree with that. And there was something that Alex said, which resonated with me. And my daughter says to me, I just want to crawl out of my skin. I'm too uncomfortable to live in my own skin. And, you know, she didn't ask to be born with this. And doctors need to understand that this is a chronic illness. No one would choose this kind of life. And addicts generally, I'm sorry, substance use disorder, people with that substance use disorder generally are not out partying. They're doing it by themselves so that they don't try to kill themselves, so that they can live within their own skin. No one would choose this. And the way that largely society sees it as people that just have low morals and are manipulative and so on, that just so badly needs to be changed. And it needs to get through. My son is in medical school and they're not teaching him anything about this. And one of the reasons he's there is because of what his sister has gone through. But it's just so difficult to see that anyone suffering with this and being treated as if it's their fault. Now, I understand if you're doing things that are against the law, you're hurting other people, but generally you're hurting yourself. And no one would choose to live that way. So I think it's just so important that it becomes clear what a chronic illness, mental illness, which drives, addictive habits, are seen on the same level as diabetes, cancer, or any other chronic illness.
So I just kind of want to piggyback off of that. I think one thing that was heard in both stories was a connection to not feeling like you can manage emotions that you're feeling or distress that you're feeling, connection to early experiences of trauma, and not knowing what that means, what that is, not even knowing sometimes that you were exposed to trauma until later in life, and not having the wherewithal or the vocabulary or, the support to even understand, what that means and explain what one is feeling. And then the recognition that, oh, I see other people managing themselves and presenting in society a certain way and able to prioritize tasks, communicate well, regulate themselves. I'm noticing I cannot. And the only way that I really know how is to try and take something to help me calm down or to focus or whatever. And I also think that I heard, you know, specifically, Alex, with what you shared, that this is kind of what I was, my family of origin, this is how they handled stress and conflict, and I didn't know any different. So there is a very strong link to with substance use disorder to trauma. And I think it just goes to show, early intervention and modeling of ways to manage emotion, ways to or understanding that you're a unique individual, feeling seen, feeling heard, and just learning how to handle distress and conflict. I think is really important.
I just want to say one other thing. So along those lines of that, to get into recovery and sobriety requires a lot of support. So the more that we are not validated and dismissed, it only furthers that person's, issues. And to look at, struggles with substance misuse and addiction, it's more of a symptom rather than the actual problem for a lot of people. It's a way to cope. It's not necessarily, it started somewhere else. And we never woke up one day and decided, I want to be in addiction. So thank you.
I also wanted to add that I do think that trauma, people that are in addiction, that they are constantly traumatized. I mean, first of all, you can just, with the medical system, with society, you're just re-traumatized. And unfortunately, if you're a woman and you're out buying drugs, you're with the wrong people, and you're in danger a lot of the time. So there's a tremendous amount of trauma on top of the trauma you already had before this started. But I do think that it's so important that, to understand like the genetic side of it, because, why does one person get a sports injury and is given opioids and he comes out okay, and another person does, and it rings a bell in his head and he becomes an addict? There is a reason that it in certain people, it just sticks. Just like my daughter saying when she had laughing gas that she knew that, she said that was the best I ever felt. I felt such relief. And I knew I wanted that the rest of my life. I'd be looking for it. So I think it needs to be looked at more as a medical illness rather than a societal deficiency.
Thank you, Nancy. Thank you, Alex. Dr. Legisetti, there are a couple of questions for you. Before I ask them, I don't know if there was anything you wanted to add.
No, I think I just, yeah, you know, you both are kind of articulating this idea of empathy for suffering, empathy for understanding that this is multifactorial, and I really appreciate that.
Dr. Legisetti, you are thanked for the presentation. It seems that transitions in care for patients that use opioids is a vulnerable period. Is there any work that's been done or is underway to support patients when they are moving within our healthcare systems? What do you see as the next steps?
Yeah, this is such a challenge. And, you know, I feel this, you know, I see patients both in the inpatient setting and also in the outpatient kind of clinic. And it can be incredibly challenging because so much of the treatment of addiction has been privatized and is out in the community. And so it doesn't exist within the healthcare system in the same way. Let's say you get your diabetes care, right? You don't kind of go to a community center to receive your diabetes care or another community center to receive your blood pressure care. Often that doctor or that care system is somewhat linked to the inpatient setting or to the emergency room. Not always, you know, in smaller rural communities, but increasingly we are seeing kind of this integration of treatment. But unfortunately, within the field of kind of substance use treatment, this has not happened, largely because the treatment setting has been kind of driven through kind of community programs, you know, nonprofit community programs that are providing wonderful care. And also, you know, unfortunately, kind of privatized settings that often are also providing wonderful care, but may also be kind of running a for-profit scheme that isn't necessarily linked to the healthcare system. And so I think until we can kind of really figure out a way to have all of these sectors communicating with each other, these transitions are going to continue to break down. You know, peer recovery coaches, and they're trying to do this. They're trying to play the connection person. And I think those approaches work really well to kind of, you know, to work within the system that we have. But I think if we were to dream bigger, these programs would be better linked.
Thank you. Another question. I work with birthing persons with substance use disorder. Can you speak a bit about the use of MAT/MOUD during pregnancy?
Yeah, this is a good question. You know, I will kind of preface by saying that I'm not, you know, an OB, so I don't practice in that setting. But from a policy perspective, this can be incredibly complicated and differ, you know, from state by state, because a lot of times women will feel nervous about presenting for care, particularly when they're pregnant, out of fear that, you know, child protective services will get involved if somebody was to find out that they were using drugs and that their baby would get taken away from them. And so again, we're kind of in this system where we need to create this safe environment that can provide the support that is needed without having people who do have a substance use disorder fearing the healthcare system. And right now, I think there's a very real fear.
Thank you. Another question, how do you think agencies that practice harm reduction can better support individuals recovering from substance abuse, as it can potentially be a trigger? Safe spaces, ? Or on-site peer support?
Maybe I could turf this to Alex, because I feel like Alex is probably better equipped than even myself to answer this.
So as a peer recovery coach, in my experience, I have had the ability to see my clients both on site and off site. And I do give them a choice of where they would like to meet with me. I kind of, every client is different. So I let them kind of lead that. I give them choices because a lot of times they don't have choices. Like Dr. Pooja was saying, that even in dealing with medication, for this is, we just don't have options. Um, so I give them options of, I let them lead the conversation. We don't always work on recovery related material. Sometimes it's just resource finding. And other times it's just being there as a support system for them and listening to them speak to me about their problems and what they're facing. So a lot of times, we just meet for coffee or we go for a walk. As a peer recovery support, I feel like a lot of my job is teaching them how to live sober and what that looks like and what healthy looks like. So doing things together that are healthy and substance free, and showing them that they can enjoy these things and do these things. And this is what healthy looks like, is a big part of that.
Thanks, Alex. Someone did put in the chat, Corewell Health System has a program that takes an HR approach for pregnant mom. Please see brochure. I didn't get the brochure in the Q&A. Oh, yes. Go ahead and send to me. Thank you. I want to read some comments. I just wanted to say thank you for this webinar. My mom struggled and suffered her whole life with bipolar and substances. Listening to the speakers makes me feel so much empathy and further understanding of what her journey was because it was similar. It makes me feel that much more motivated to get into the social work psychology field and help others. Just wanted to thank everyone for their testimony and continued education. Thank you also for the reminders to promote a healthier outlook, even by changing our verbiage. Thank you, Alex, for sharing your testimony and for your valuable contribution, citing that using drugs is a symptom rather than the initial cause. No one wakes up and decides to use drugs. Well said. Nancy and Alex, thank you for sharing your experiences. You both have a lot of courage to come forward and share. I have no questions. I just want to thank you. And thank you, Nancy, for highlighting the fact that drug use is a health condition like any other. I'll add my thoughts on the question about how do you think agencies that practice harm reduction can better support individuals recovering from substance abuse, as it potentially can be a trigger, safe spaces / on-site peer support. I'm guessing that this is being asked in the context of, perhaps we are serving both people that are still actively using and serving people that are no longer using and don't want to be exposed to substances. And while this is a question I don't have an answer to, I have worked in these facilities, and I think that what I have seen in the field is moving more towards some separation in treatment and support around the actual services that are being given, but also more combination of peers along with people in active use, or peers also with people that are not exposed to substances or using substances at all. And I think it's a great question for an agency practicing harm reduction. I know there is an agency called Voices for Hope, and they're out of Kentucky. Their speaker, they had a speaker that represented their organization at a couple of conferences that I recently attended, and would be a great an agency to reach out to. This is just a really good question. I think a lot of organizations are wrestling with. I can also drop the link to Voices of Hope in the chat. There is a comment. I really see the fact the mental health and substance use are most separate from medical. It is very difficult to get information and share for treatment on the whole person. I work in mental health, no substance use. Integrating is the key. Agreed. Thank you. So many more people need to hear this. Thank you, Alex and Nancy, for sharing. How many people don't follow their diabetic or blood pressure plan? All illnesses need to be treated the same. Enjoyed this presentation. Thank you for your personal experience. My son has bipolar and he struggles daily. I related personally to Nancy's experience. Thank you. Thanks everyone for your participation today. Thank you, Alex. Thank you, Nancy. Thank you, Dr. Legistetti. Much appreciated. As Sarah mentioned, we will send an email with the follow-up CME Social Work McBath credit information. And with that, we will let you go, and we wish everybody a good day, and thanks for attending today. Take care.
Thank you, everyone.
Thank you.
Thanks.